Still waiting. Hello, everyone. Welcome back to another Mind to the Bleep webinar from the Neurology team. I'm Alex Gordon. I'm an F1 doctor in Torbay Hospital. I've got my colleague Terry as well.
Hi, hello.
Yeah, sorry, Terry, cut you off.
That's all right.
Crack on, Terry.
Hi, hello. I'm one of the Neurology co-lead as well.
And Terry is an F1 in the Guildford area in Surrey. I think my knowledge of geography outside of the southwest is limited at best. So tonight was originally going to be on functional neurological disorders, but we had, due to sort of unforeseen circumstances, had a last-minute change of speaker. So we've actually got next week's session on peripheral nerve disorders that's been rearranged to tonight. So sorry if any of you were expecting to come to a talk on functional neurological disorders, but we will try to rearrange that for the future. As always, you can view all of our webinars, including tonight's, via YouTube as well as on Medal, and all the slides from the previous talks are now available to download as PDFs as well for those of you looking to revise. As always, if you can provide feedback via the link that we'll upload in the chat, and also there'll be a QR code at the end of the presentation for tonight, you will get a certificate that you can use in your portfolio and for CPD. So I'm now going to introduce tonight's speaker, who is Dr. Jamie Talbot, who is an ST5 neurology registrar at the Royal Devon and Exeter Hospital currently. Who's going to talk to us tonight about peripheral nerve disorders. So, Jamie, away you go.
Okay, brilliant. Thanks very much. So, yeah, I'm Jamie Talbot, working at Exeter at the moment, and I'm an ST5 in neurology. And I'm going to do this presentation on peripheral nerve disorders. And I'm sorry if anyone was expecting a presentation on functional disorders, but peripheral nerve disorders is probably a bit more of a dry topic, but I'll try and make it as interesting as possible. So I'll just outline the direction of travel, so to speak. I'm going to start by just talking about the anatomy and terminology associated with peripheral nerve disorders, because it can get a bit confusing. And then I'll try and then basically the aim of the presentation is just to prepare you a bit to think about presentations of peripheral nerve disorders and the way you should really approach them when thinking diagnostically, ways and clues that you can pinpoint where the problem is, and with the hope of reaching a diagnosis. Then I'll talk about some neuropathies not to be missed, and then finally I'll talk about peripheral neuropathy, just the bread and butter of neurology, really. So peripheral nerve disorders can be a bit complicated, and there's all this terminology. If you ever get a nerve conduction study report, you'll see a lot of these terms thrown around, things like demyelinating ganglionopathy, neuronopathy, and you can sometimes feel a bit overwhelmed by what it all means, and I think we do too, to some extent, because the neurophysiologists are very much purveyors of the realm of peripheral nerve problems. So it takes a bit of getting used to and understanding the terminology. In terms of the anatomy, you can think of the peripheral nervous system as anything from the spinal cord, where the nerve roots exit the spinal cord. Well, from the anterior horn, really, would probably be the first place to start from a motor point of view. From the motor fibers leave the spinal cord via the ventral root, whilst the sensory fibers leave via the dorsal columns and the spinothalamic tract. For motor fibers, the cell body is within the anterior horn, whereas for sensory fibers, the cell body of the axon is just outside, just next to the spinal cord. And then the two pathways converge into the peripheral nerve, and then the nerve travels all the way down to neuromuscular junction, where there is a synapse, and then to the muscle. And it's important to know that the nerve fibers contained within the peripheral nerves are all slightly different. So it's the smallest of the fibers which are unmyelinated, so the slowest conducting, and they contain autonomic fibers and also sensory fibers containing pain and heat sensation. And interestingly, these small fibers never really get tested when with nerve conduction studies. They're just too small. So whenever you're looking at results of nerve conduction studies, they're really looking at results from slightly larger axons, so motor fibers and also sensory fibers carrying more sort of vibration sense and things like that. So I'll talk a bit about nerve studies, and again, this is a subject which people get very tied up about, and it can be very confusing. In reality, it's probably not as confusing as all that. There's a lot of terminology, and it's very much a specialist area. But actually, when it comes down to it, the principles aren't really that confusing. The nerve studies themselves are really doing what they say. They're testing the nerve specifically. So it's basically, the way it works is that there's a stimulating electrode and a recording electrode, and you apply some electric shocks to stimulate the nerve, and you're just recording what happens. And you can look at the sensory responses, or you can look at the motor responses. And in terms of the sensory responses, you're given the shock and then reading the action potential that you read at the recording electrode, and you can usually glean two main things. You can look at the latency, so how long it takes for it to arrive, and by that you can work out the conduction velocity, which gives you an idea about the myelinated fibers and how quickly things are conducting, and also the size of the action potentials. That gives you some idea about whether there's a more axonal neuropathy rather than a sort of demyelinating problem. And it's the same thing with the motor responses. Again, you're looking at how quickly they conduct, and whether there's any sort of axonal damage, which would lower the sort of amplitude of the CMAP. There are some other things that you can look at in the nerve studies. There's these things called F waves, which you sometimes see referred to. Essentially, they are after the main action potential. They're slightly a slight hump, which represents, and those basically represent the nerve impulse traveling backwards up the nerve all the way up to the nerve root and around the area of the spinal cord, and then coming back. So there's a delay, but they're quite useful, especially if you're wondering about a more proximal lesion, something closer to the spinal cord, like in the nerve roots, which may just be a bit too upstream to test when you're looking at when you're testing nerve studies in a conventional way. So that's nerve studies, and then the EMG is technically completely different. Basically, with the EMG, you're sticking a needle in the muscle, and it gives you an idea basically about the nerves supplying that muscle, and also the muscle fibers themselves. And there's a few things that they look at. First of all, it's just the spontaneous activity. So they put the needle in the muscle and the muscle's at rest, and you record the pattern recorded there. Then you can do something called smooth contraction, where you just kind of gently contract the muscle, and that gives you some idea about the individual sort of shapes of the sort of muscle unit action potentials. And then you can ask the patient to do a sort of maximum contraction of the muscle, which often referred to as an interference pattern, where you basically get a whole interconnected run of these muscle unit action potentials all kind of joined up. And again, it gives you some valuable information. I'll talk about these things in a second. There are some other tests that you can do with nerve studies, for example, repetitive stimulation and single fiber EMG. Both of them are quite useful, in particular for looking at myasthenia gravis. And they basically, with repetitive stimulation, you're giving a series of shocks and then seeing if there's a decremental response typical of myasthenia. And the single fiber EMG, you look for something called jitter, again, which would be suggestive of myasthenia. So talking about the EMG, so this spontaneous activity, as I mentioned, where you just put the muscle in and see put the needle into the muscle and see what happens. And sometimes you can see these spontaneous depolarizations. There's different shapes depending on what you see. These that are often referred to as positive sharp waves and fibrillation potentials. I mean, usually in a normal muscle, it should just be flat, as you can see below. But these, when you see these spontaneous depolarizations, they're basically implying that there's a neuropathic process, some damage to the nerve that's occurring. For example, motor neuron disease or any process affecting the nerve. So slight effort, again, you start to see the waveforms of these motor unit action potentials. That's on the left of the screen. You see a normal motor unit action potential, which is often referred to as biphasic or triphasic. So there's a couple of deflections of the spikes, and where there's been damage to the nerve, what you tend to see is that the motor unit action potential is quite long in duration. It's quite high amplitude, and often you see quite a few deflections. It's kind of polyphasic form to it, whereas the myopathic motor unit action potential is much shorter and it's really low amplitude. So you can kind of distinguish between these two processes, and that's the interference pattern with the maximum effort, as I mentioned. And again, you can clearly see differences between a kind of neuropathic pattern of damage. Instead of getting a continuous stream of activity, you get a kind of more punctuated activity with quite tall complexes, whereas in the myopathic EMG, you just see that it's generally reduced, a continuous stream. So that's basically nerve studies in a nutshell. For us neurologists, we kind of read the reports and you see a lot of similar terminology referred to, but that's a basically watered down version, the simple version of what that entails. So I was going to go on and talk about just an approach to nerve problems and how you should approach them and how you can think about what's going on. There are a huge number of diseases and pathologies which can result in damage to the nerve, and it gets extremely complicated sometimes. So and there's a lot of different tests you can do. So so it's good to have a process in your mind to think about things in a rational way and logically. So one way to think about peripheral nerve problems is just trying to localize the problem anatomically. And I made this diagram. You can kind of think about which bits of the nervous system are affected. So so if we start right at the beginning in the anterior horn, some processes are notorious for affecting the anterior horn. So motor neuron disease is one of them, especially the sort of progressive muscular atrophy ones, and also ALS. And there's some other pathologies which kind of localize to the anterior horn, spinal muscular atrophy, polio. Then spreading out a bit more distally, the nerve root and the nerve plexus. Common things that can affect the nerve root and plexus is trauma is a classic one. Often you get associated pain, disc slips and causes a bit of compression with the nerve, often with associated pain. And it's often the location of diabetic amyotrophy. In terms of sensory problems, the dorsal root ganglion is it's quite a rare location to have a problem, but when you do see patients with dorsal root ganglionopathy, so this is quite a niche term, ganglionopathy or neuronopathy. They're basically the same thing, but they both mean that they localize to the dorsal root ganglion, which is the sensory ganglion. And when you do see a problem, what you often see is autonomic. It's a failure of autonomic function, and also kind of often get painful neuropathies. And there's the processes that tend to affect the dorsal root ganglion tend to be inflammatory. So you often see it in sarcoid or Sjogren's. There's a specific antibodies to alpha-3 ganglionic antibodies, very rare, but that often picks off the dorsal root ganglion. Paraneoplastic syndromes can often do that. Amyloidosis is also a sort of favoured site. And then as you get right to the end of the nerve, you get a lot of the problems which causes what they call a length-dependent axonal neuropathy, or a sort of dying back neuropathy. And this is what is often synonymous with peripheral neuropathy. So it's the things like diabetes and hypothyroidism, which is affects the longest nerves of the body most. So you have the longest nerve, so it's usually nerves in the leg, which are most affected, and it affects the distal part of the nerve. So which is why you get that glove and stocking distribution. And common causes for that are things like diabetes and alcohol, and also sort of toxic agents like the chemotherapy agents. There are some processes which affect the length of the nerve, and have a more sort of complete pattern of distribution. I haven't put many on there because there probably are loads of them, but classic one for that is Guillain-Barre, where you have the whole of the nerve being affected. Usually it's a bit patchy, and then hereditary motor sensory neuropathy, i.e. Charcot-Marie-Tooth, where you also get the whole nerve tend to be affected. And then you can get Mononuitis Multiplex, which is basically a problem in the distribution of more than one peripheral nerve. So it'll be radial nerve and ulnar nerve or something together. And usually when you see that, it's connective tissue disorders. They can usually be quite nasty processes. Things like vasculitis and connective tissue disorders like rheumatoid arthritis can cause mononeuritis multiplex. Again, on the theme of localization, you can also think about things as being axonal or demyelinating. So this is just demyelinating problems. So again, there's a kind of collection of disorders which often tend to cause more of a demyelinating problem. So obviously the Guillain-Barre and CIDP are demyelinating problems, but you also see them with some infections like HIV and diphtheria, inflammatory causes, paraneoplastic causes, and then I've shown this the nodes of Ranvier. So there's one particular disorder called multifocal motor neuropathy, where this specifically has is antibodies targeting the nodes of Ranvier, so you get a sort of conduction block. So again, approaching neuropathies, another good way to think about things is how quickly they come on, because that's probably one of the most useful things to think about in terms of what the neuropathy represents. So if something comes on overnight, fine when you go to bed and you wake up the next day, the things you got to think about is whether there's some injury, and usually you will hear a story of some trauma, or the what do you call it, Saturday night palsy, where you sort of drink too much and fall on your hand. You've got radial nerve palsy the next day. So you often do have that history, although it's not uncommon that you do. There isn't an obvious injury process, and even there isn't necessarily associated pain, but you often get the nerve studies and see there's been some sort of damage there. So injuries are classic. And then inflammatory causes, especially involving the nerve, things like Guillain-Barre. There are other causes as well, rare things that you basically never see, things like thallium toxicity and some genetic things, acute intermittent porphyria. HNPP, as I've written there, is the hereditary neuropathy with liability to pressure palsy. So it's a genetic disease where you just your nerves are very susceptible and sensitive to compression. So it's kind of an injury, but on the background of a genetic problem. Subacute things tend to be inflammatory. So CIDP, CISP is a kind of sensory variant of that. Again, these subacute things are usually coming on over days or weeks. Things like vasculitis. Vasculitis is a common cause of nerve problems. Although rare overall, nerves are often affected in vasculitis processes and can be quite nasty. And then you can have the other sort of systemic autoimmune processes. Again, things like diabetic amyotrophy, infections, hematological things can often present in a subacute way. Critical illness polyneuropathy as well. That's something we commonly get asked to consult on in the intensive care patients who've been in for a couple of weeks and have had a stormy course and been intubated and ventilated, and then they're very weak. So that's something you see quite a lot, and that usually comes on over days or weeks. And then thinking about things in the chronic causes. So this is usually the kind of the peripheral neuropathy, the axonal length-dependent neuropathy, and it's usually things like diabetes, chronic alcohol use, drugs in the past, B12 deficiency, all those kind of things. And sometimes you see hematological paraproteinemias also kind of having that kind of chronic problem. And then of course genetic diseases, things like Charcot-Marie-Tooth, and some other diseases which are associated with nerve problems, they're very slowly progressive neuropathies. I mean, that's usually the hallmark of genetic diseases. It's a very slow progression over months or years, over years. And then you can think about things in terms of what's affected. Is it sensory? Is it motor? Is it sensory and motor? Is it autonomic predominant? For the most disorders affect sensory fibers and motor fibers reasonably equally, but there are some things which are more sensory, things like the diabetes and B12 deficiency, the ganglionopathies, the dorsal root problems. And then some things are slightly more motor. So in particular, the A-man, which is the motor variant of Guillain-Barre, that can be a pure motor form, which often comes on quite quickly. And it can often throw people off quite a lot because Guillain-Barre are usually associated with kind of some numbness and tingling and things like that. But you can get this pure motor form. And similarly, you lose your reflexes and stuff, but that often catches people off guard. Multifocal motor neuropathy. And then obviously processes which like motor neuron disease and neuromuscular problems like myasthenia gravis offer, if it's pure motor, you really start to think along those lines of is it the neuromuscular junction or muscle? And then there's some autonomic predominant diseases. These are things which usually affect the dorsal root, so inflammatory problems and amyloidosis, for example. So I thought the best way to talk about approach to nerve problems was to go through some cases and from there basically try and discuss it. I've set this up as a voting system, so I'll try and do that. I might have to duck out of the presentation, but we'll see how it goes anyway. So this is the first case. A 53-year-old man with type 2 diabetes developed over the course of several days burning pain in the right hip and thigh, which slowly spread to the entire leg. A week after the pain began, he developed weakness in the leg, which progressed over a couple of months, requiring use of a stick to walk. He continued to suffer with severe pain, demanding opiate analgesia to manage the pain effectively. Examination revealed weakness throughout the right leg with absent reflexes and mute plantar responses. Sensation was intact. He continued to experience weakness for 18 months before starting to experience some slow improvement in symptoms. All right, so if we try and bring up the voting system. Okay, so I think if you scan the QR code thing in there and vote, we'll see how it goes. If it doesn't work, we'll just we'll give it a miss. So select the most likely diagnosis. Okay, I'll give it, see what people are going. I'll give it 10, 20 more seconds. Okay, so I think if we stop it now, show results. Yep, perfect. That worked quite well actually. It is diabetic amyotrophy. So if we think about it, so this guy, he's got diabetes, and he develops on one side in the leg a lot of pain and with associated lower motor neuron signs. So this is basically classic of diabetic amyotrophy, and it's one of the neurological complications of diabetes. There's a few, but it's tends well, I'll show you it. So diabetic lumbar sacral radiculoplexus neuropathy. So it's a monophasic neuropathy. So it typically presents over weeks to months, and asymmetric. It's almost always asymmetric, and there's really significant pain with it. And then the weakness kind of develops alongside, and over time the muscles atrophy. Reasonably rare. And it's mostly middle-aged patients with type 2 diabetes and mostly men. and sometimes it's after they've been losing weight. And interestingly, they tend to have better than average glycemic control. Interestingly, it's a weird phenomenon. But yeah, it often progresses over a number of months, and it can be as long as 18 months, and it really can be very nasty and cause really severe pain. People really struggle with it, and it can take years to recover properly, and often even then it's incomplete. So yeah, that's that one. Sorry. So next case. This may be a bit more difficult, we'll see. So a 50-year-old man with no medical history presented with worsening postural hypotension with burning pain in his trunk and limbs. He had lost a significant amount of weight and also complained of erectile dysfunction. His nerve studies were unremarkable, and CT tap did not reveal any malignancy. Serum electrophoresis was negative for any paraproteinemia. However, urinary Bence-Jones revealed a significant lambda light chain paraproteinemia. Okay, so if we go back to the poll. Okay, so if everyone wants to vote. All right, so I'll give it 10 more seconds. 9, 8. Okay. Interesting. So you voted anti-MAG neuropathy as the most likely, then POEMS, then systemic amyloidosis, and then diabetic neuropathy. Interesting. So I'll bring up the presentation again. So the answer is systemic amyloidosis, and that's a tricky one. I put in some random diagnoses to fool you. Anti-MAG tends to be a very slow progressive, and it's usually a sensory neuropathy. So it's patients have a really profound sort of sensory neuropathy. Amyloidosis, both POEMS and anti-MAG are associated with paraproteins. So they are both, you would expect to see paraproteins, although they're usually IgM related paraproteinemias. POEMS is IgG, but anti-MAG is usually IgM. So this was systemic amyloidosis, and the reason for that is because of the prominent autonomic involvement. The other two, POEMS and amyloidosis, are probably less likely to cause autonomic problems. So we had a patient like this on the ward recently, and it was basically exactly as I described. This chap who felt very unwell, losing lots of weight, generally feeling quite terrible, and he had really profound autonomic symptoms. So, even standing up made him feel really dizzy. He had these profound drops in his blood pressure, and this kind of neuropathic pain, which is kind of non-length dependent in a way, affecting the trunk. So, and he had a light chain paraproteinemia. So again, all those things, that very profound autonomic symptoms suggest, again, it tends to suggest a ganglionopathy or a neuropathy affecting the dorsal root ganglion. And as I said earlier, there's a few things which there's a limited range of conditions to consider when patients present with lots of autonomic findings. So it's inflammatory stuff like Sjogren's and sarcoid, this alpha-3 anti-ganglionic acetylcholine, paraneoplastic stuff, previous chemotherapy. So if you do see patients who are presenting with a lot of autonomic dysfunction, have those things in mind, and especially sarcoid CT scanning, looking for any lymphadenopathy. Send the electrophoresis, and the light chains, because often the light chains give it away and the serum electrophoresis can be normal. So always send the urinary Bence-Jones. And management of those symptoms can be very difficult indeed. So you tend to involve applying people with fluid, making sure that they drink loads before getting up and doing anything, loads of salt. They often have, because the body can't regulate the blood pressure, patients typically have high blood pressure at night, low blood pressure if they stand up. So you often have to give them anti-hypertensive at night. And then there's some pharmacological options which usually kind of squeeze blood vessels and kind of boost fluid in the body. So that's great. Right. Next one. A 19-year-old woman attended the neurology clinic with a long history of leg symptoms and struggling in relation to her peers. She recalled symptoms since at least the beginning of secondary school, including frequent tripping when walking to and from classes and poor sporting achievement, including fatigue and calf pain during exercise. Examination revealed high stepping gait bilaterally with weakness of ankle dorsiflexion, reduced ankle reflexes, and high arched feet with hammer toes. Nerve studies showed slowing of motor nerve conduction velocities and sensory action potentials in median and sural nerve territories. So we will go back to the voting. Okay, so I'll give you some time to select what you think is the most likely diagnosis. All right, 3, 2, 1. Yeah, well done. Yeah, Charcot-Marie tooth. So that's the clear winner. So Charcot-Marie tooth, also known as hereditary motor sensory neuropathy. So this is a genetic condition. And there's a lot of genes which can cause Charcot-Marie tooth, and seemingly an ever-increasing number of genes. But it's 4 of them which account for most of the cases, 90% of them. And it's all got a bit confusing as they found more genes. So this is the kind of system they have for labeling CMT. You've got CMT 1, 2, 3, 4, 5. So that implies 1 is demyelinating, 2 is axonal. It does have other qualifiers as they go up, but it gets a bit confusing after that, and some of them are obsolete. And A, B, C basically refers to the gene that's involved. So it's a kind of system of classification. The hallmark clinical features to suggest this at the time. So it's a very slow progression. First of all, she's very young, and she developed the symptoms when she's quite young, and they've slowly progressed from there. And really, she's had these the weakness is predominantly in her ankles. She's got weakness of dorsiflexion. She's got the characteristic high arched feet. So those were the kind of clues in there, and certainly the very slow progression and the kind of the pattern of distribution would be very suggestive of Charcot-Marie tooth in her case. So we'll do another one here. A 40-year-old man noticed increasing problems with right hand function over a period of 9 months with some intermittent cramping sensations. He denied any sensory symptoms, so it's pure motor, and was otherwise well. Clinical examination revealed some fasciculations in the first dorsal interosseous muscle of the right hand and weakness of finger wrist extension and grip. Sensory examination was normal. Nerve studies showed prolonged motor nerve latencies and slowed conduction velocities in the median and radial nerve territories of the right arm, with a greater than 50% reduction in the CMAP amplitude between proximal and distal nerve stimulation sites, indicative of conduction block. Okay, so I will bring up the next poll. Okay. So I'll give you a bit of time just to vote on this one. Okay, 3, 2, 1. Okay. Oh, that's very interesting. So the correct answer is actually multifocal motor neuropathy. But for those of you that said amyotrophic lateral sclerosis, or really any of them, you wouldn't be wrong to think that at all, and that would certainly need to cross your mind as a differential diagnosis. But I'll explain it, why it was multifocal motor neuropathy. Again, a lot of these cases are a bit esoteric, but I think it's sometimes useful just to know some of these other causes and just be able to think about things in contemplating what the likely diagnoses are. So, so multifocal motor neuropathy is an autoimmune process which affects the nodes of Ranvier, and tends to be quite young patients, to be honest. It's mean age 40, but you often see patients in 20s and 30s having this. And the real giveaway from the case that I presented was the nerve studies, which showed this conduction block, because conduction block is often it's basically synonymous with demyelinating problems, and it's often pathognomic of multifocal motor neuropathy. What patients tend to have is very asymmetric, painless limb weakness. Sometimes there may be some cramps also, but limb weakness, usually distal. It's usually in a couple of nerve territories, and usually in the hand or in the distal part of the body. Kind of slow progression, and it's a pure motor thing. So so again, the people who said motor neuron disease or ALS would be right to have that in mind, because yeah, and it's one that you don't want to miss. So Lewis-Sumner syndrome I put in there as well as a differential. That's basically a sort of asymmetric form of CIDP. I guess the thing leading away from that would be the lack of any sensory findings. Often you would have sensory findings with that, so that kind of makes that less likely. Anyway, multifocal motor neuropathy. There's a good test that you can do for that called anti-ganglioside antibodies, and often patients have anti-GM1 antibodies. And it's a treatable condition, this. And it's young people, as I said. So so IVIG tends to be the treatment that works, and patients don't respond to steroid or plasma exchange, unlike patients with CIDP. So it's a bit of a weird one. So I think there's one more of these, but we're now entering the next bit of the presentation, the neuropathies not to be missed. So an 18-year-old man was brought to the emergency department by his parents after he collapsed at home. He had struggled in a football game 3 days ago, and from there had experienced worsening shooting pains in the arms and legs and became increasingly weak, today barely able to get out of bed. In the emergency department, his pulse was high at 140 beats per minute, and he went into urinary retention, requiring catheterization. He displayed weakness of all 4 limbs, MRC grade 3 out of 5 bilaterally, with associated patchy numbness. Reflexes were globally absent. So we'll put it to the vote. I think this is the last one. Okay, so get voting. All right, 3, 2, 1. Fantastic. Yeah, Guillain-Barre. That's the right answer. I'll tell you. So Miller-Fischer syndrome is a variant of Guillain-Barre, but that tends to be a sort of involving bulbar function. So patients typically, or with sort of cranial nerve symptoms. So patients typically have eye movement problems, or facial weakness, or swallowing problems, speech problems. So so that's Miller-Fischer syndrome. So it's more of a kind of in the head problem. Critical illness neuropathy, as I said, it's usually associated with people being very unwell with other problems, although it can present quite acutely. So, and myasthenic crisis wouldn't be the one, just because there's some patchy. He had some patchy numbness as well. So, even though it can present with acute deterioration like that. So if he deteriorated like that and very quickly and had pure motor phenomenon, you would consider myasthenia. So I talk about Guillain-Barre is it's a common condition, and it's one that's potentially very dangerous. So and it's one that you'll have to manage at some point in the medical assessment unit. So I'll talk about the gold standard management and what I would suggest for this patient. Obviously, the ABCDE approach to all these things. So this guy, he is a bit of a concern, to be honest. So he's gone into urinary retention, and his heart rate's really high. So he's got some evidence of autonomic dysfunction. Any patient with GBS, the autonomic dysfunction is the thing that you're going to worry about and that you want to keep an eye on. One of the things. So all patients with GBS should really be hooked up to a heart monitor, and they also need hourly or several hourly FVC measurements, and put them in an open bay to look for any sort of progressing respiratory muscle weakness. And it's important to just flag these patients up to the nurses to make sure that they know that they have the potential to deteriorate, and that people are keeping an eye on them, and to flag up any deterioration. So with this patient, I would discuss this patient with people. I'll give the neurology team a buzz if they're available in the hospital, because GBS is a treatable problem. You can give. It does sort itself out spontaneously anyway. It's usually a monophasic illness, but by giving IVIG or plasma exchange, patients can recover quicker and hopefully not develop the horrible respiratory muscle weakness and things like that. So I discussed with neurology to think about sorting out some IVIG, and the IVIG tend to be given by the blood bank. So as dosed by weight, it's usually 2 grams per kilogram over 5 days. So it's about 0.4 grams per kilogram per day. So so knowing the weight can be useful. Sometimes you just have to estimate. With this guy as well, I probably would speak to ICU. He's got this evidence of autonomic involvement, and these are the patients that really are going to potentially do badly. So I would be speaking to ICU, even if they don't want to take the patient. It's worth the patient being on their books just so they know. And then some investigations can be quite useful. Lumbar puncture is useful. The typical lumbar puncture finding is you see a high protein with normal cells or no cells in the fluid. So this kind of albumin cytological dissociation. You don't have to see it. The protein can be normal. It doesn't rule anything out, but it helps and helps with the diagnosis. You can send these anti-GQ1B antibodies. They won't come back for several weeks, but it may give you some idea. And nerve studies, again, we often use them, but sometimes the changes don't become apparent for a couple of weeks, and they're not going to change things in the short term. It's a kind of clinical diagnosis, but it's a test which can be helpful. And it's important to remember that even though it looks just like Guillain-Barre, there are masqueraders and mimickers. So Lyme disease can mimic Guillain-Barre. It can come on quite acutely. You can get other infections like diphtheria and HIV. You have sort of vasculitis and things presenting in this manner, poisonings. So it's worth keeping in mind differentials, and that's why lumbar puncture can be quite useful. That even though it looks like Guillain-Barre, if you do a lumbar puncture and there's loads of cells in it, you're probably going to start thinking, is this Lyme disease or something else? So it can be very useful for just thinking about alternative causes. GBS, classically, it's symmetrical. It comes on acutely and it's symmetrical. It's never asymmetrical, really, unless, basically never in the acute GBS. Patients typically have radicular pain, so there's a nerve-related pain, and autonomic disturbance is quite common. Often it's not too severe, but The mortality associated with GBS tends to be the autonomic problem. So, and the overall mortality is low. It's 3 to 10%, but it's usually due to cardiac arrhythmias and blood pressure instability. 20% of patients require mechanical ventilation, and the outcomes are usually quite good. So 60 to 80% of patients are able to walk independently 6 months after disease onset, with or without treatment. So people have a good outcome, although they often need a bit of rehab and things like that afterwards. And as I say, it's classically a monophasic illness. It won't recur. It runs its course within a matter of sort of 4 weeks or so, and then improves. So you do hear about these relapses sometimes, very rare. And there are these subtypes, which AMAN's the motor variant, so you don't get the sensory signs and things. And AMSAN, I think, I'm not even sure, to be honest. It's very rare. And then there's, I can't remember if I did this as a okay, we'll skip the vote. I can't remember if I did a vote for this, but anyway, I'll talk you through this case again, thinking on the lines of neuropathies you don't want to miss. So 70-year-old woman attended the neurology ambulatory clinic with a 3-week history of weakness and numbness in her hands and feet, with associated pain and swelling. She felt generally off sorts and had experienced some night sweats. Her only past medical history was of hypothyroidism. On examination, she had significant weakness and numbness of the hands and feet in a glove and stocking distribution. Her bloods revealed an eosinophilia and CRP of 250. P-ANCA was positive with MPO antibodies. So her diagnosis is vasculitic neuropathy. And these can be very nasty indeed when they occur. Whilst the typical clinical syndrome is mononuitis multiplex, so you know, in the kind of in a single, more than one peripheral nerve territory, patients don't infrequently present with a kind of glove and stocking kind of distal symmetric neuropathy, but you know, as quite a rapid onset over kind of days or weeks. And the vasculitic neuropathy is basically within the sort of pure vasculitis diagnosis contains this microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis, and this other one, granulomatosis with polyangiitis. She's got eosinophils in the blood, so it'd be the eosinophilic granulomatosis, but they're all quite similar. You can't really necessarily distinguish between them that well. And obviously you can get vasculitis in the context of other sort of more systemic problems and connective tissue disorders like rheumatoid arthritis, Sjogren's, lupus, sarcoid, and there are also infections as well, like B and C, especially with Hep C, get cryoglobulinemia, which can cause quite a similar pattern as well, and that's kind of a vasculitis in its own right. So important not to miss. I've copied this table just from a paper on suggested workup in subacute in sort of vasculitis neuropathies, but probably a good one to have in mind just when you're when patients present with a kind of rapidly evolving neuropathy. So checking the hepatitis B and C serology will be very important. Cryoglobulins, you know, you don't send them that often, but certainly if someone was presenting with you know, rapidly progressive neuropathy, you probably would. You want to send HIV and infections and things like that, and cerebral spinal fluid analysis is quite useful as well. Some of these I've never heard, so I don't know what soluble interleukin-2 receptor is, but so don't worry about that. So yes, I think the paper was probably a bit out of date, but you get this general immune screen. I've got my own sort of immune screen which I send off for all this stuff. So you usually have sort of lupus anticoagulants and anticardiolipin antibodies, ANCA, ENA, ANA. So so there's, and the complement as well. So getting towards the end of the presentation, the last bit I'll speak about is just peripheral neuropathy, or you know, the distal axonal neuropathy, which is basically the daily slog of neuropathy. So this is a typical example of a sort of peripheral neuropathy. 67-year-old man presents to the neurology clinic with a sensation of walking on sponges for a couple of years. He notices some difficulty with balance when getting up in the night to go to the loo, but is otherwise functioning well. He also describes unpleasant tingling pain in his toes. On examination, Romberg test is positive, and he has reduced sensation to all modalities up to his mid-shin. Lower limb reflexes are reduced with absent ankle jerks and equivocal plantar responses. So that's the classic peripheral neuropathy presentation. That Romberg's test is usually, although it does test a few things, its main purpose is for testing for proprioceptive difficulty, which is classically kind of eliminated in peripheral neuropathy. So patients are often Romberg's positive, and at night as well, it's very dark, so you take out your vision, so you can't see much, and you're relying on proprioception. So patients often report this poor balance in the middle of the night. And you'll hear lots of terms to refer to this distal axonal neuropathy, this dying back axonopathy. So the fact that it kind of starts at the end of the axon and kind of works its way back, and the neuropathy can kind of spread upwards. And it represents 90% of peripheral neuropathy. And there's loads of things that can cause it. I think I read some paper that there was over 100 different problems and diseases and medical things that can cause this kind of peripheral neuropathy. So there's a lot of things, and it's very common. So apparently prevalence of around 1% in the general population and rising to 7% in the elderly. I'm not sure exactly when the cutoff for being elderly is, but it's quite prevalent. And a lot of times you just don't know the answer. So idiopathic in 20 to 30% of cases. So despite checking all the HbA1cs and things like that, you just don't find a cause, and it can be quite frustrating when that's the case. But hopefully we may make some progress with it in the future. The most common causes: diabetes and alcohol, as you'd probably expect. So when you're taking a history, asking about alcohol use is essential. And it's always worth asking about previous chemotherapy and cancers and things like that, because they often lead to this kind of chronic neuropathy as well. B12 deficiency is a classic one. I often find that you can sometimes detect this just, you do a neurological exam on someone who's come for something completely different, and the reflexes are reduced, and they'll have some reduced proprioception or something in the toes, and you might just pick up a incidental low B12. So you do just pick these things up, and that's a common cause. Hypothyroidism, sometimes see it in general sort of metabolic disturbances. And then these paraproteinemic associated ones. So sometimes it can be associated with just monoclonal gammopathies of uncertain significance. And you can also see it as association with, the sort of anti-MAG and things like that as well. And then other sort of systemic processes, uremia, kidney failure, liver failure, things like that, you can see it in. You could go as far as you like investigating for these neuropathies, but for the most part, there's probably a quite limited number of tests which will kind of give you, an answer, and usually further investigation doesn't help a huge amount, unless there's something atypical about it. So I suggest that for a basic neuropathy screen. CRP can give you general idea if there's an inflammatory process. If it's very high, then you investigate further from there. Diabetes screen, thyroid screen, B12 and folate, and serum electrophoresis Bence-Jones, and sort of general bloods. That's what I would recommend. And pain can be quite disabling. So the evidence, I think, still is that duloxetine tends to have the best evidence for treating neuropathic pain in those sort of disorders in peripheral neuropathy. So duloxetine is a pretty good one for going first line, but other options are amitriptyline, gabapentin, pregabalin, and probably a load of other ones as well. So that's the presentation. My conclusion really is that there are many neuropathies, many different causes, kind of a dizzying number of causes. And so thinking about things in a systematic way is probably the best way to approach them, and just to know that there are a lot of different causes, and to and by thinking logically about it, you can kind of hone the problem down. So I think the most important things are the onset, how quickly it came on, the distribution. So is it a kind of glove and stocking distribution? Is it a mononuitis multiplex? And Again, is it pure motor? Is it sensory? Pure sensory? Is it a mix of the two? Again, is there pain or is it non-painful? Painful things are often in nerve entrapments and things like that, and diabetic amyotrophy. So they give a lot of helpful information, and so you can start to refine things. Are they symmetrical or asymmetrical? Again, is very important. A lot of neuropathies you won't necessarily get to the bottom of, but acute and subacute neuropathies are always concerning, and there are often treatments for them. So so if people come in with symptoms and signs suggestive of neuropathy and it's all evolving very quickly, I'd have a low threshold for speaking to a neurologist and investigating for lots of sort of inflammatory things. And lumbar punctures can be very helpful for all kinds of things, for things like vasculitis, CIDP, Lyme disease, mainly demyelinating stuff, but yeah, they can be very useful. And I thought it was just worth reminding you that even neurologists find the peripheral nervous system very difficult to navigate, and I'm frequently on Google searching which myotomes are supplied by whichever routes to if I've seen a tricky case. So so it is tricky. The neurophysiologists are probably the best people at nerves problems, but we do our best. So so that's the end of the presentation, and I will I don't know if anyone's got any questions, or I'll head back to chat. You can write them in the chat if you want, or ask.
Yeah, thanks so much, Jamie. I'm just having a look at the chat as well. We posted a link in the chat. There is a slide as well, just spotted at the end with QR code, but lots of people seem to watch this on their phones.
Yeah, sorry.
So.
There you go.
Sorry.
I'll put that on.
Yeah, if anyone's got any questions, please fire away. If you want to watch it back, it will be uploaded on YouTube within the next 48 hours, as well as hopefully, Jamie, if you're happy to send across the slides.
Yeah, absolutely. Yeah, of course.
That would be fantastic. We'll probably just wait a couple of minutes for questions. Don't think so. I normally try and come up with one myself at this point. I was just wondering, with the a lot of the time with neurology, you tend to have to order sort of autoantibody stuff when you start getting towards the more niche side of things.
Yeah.
And often those take quite a long time to come back. I don't know if there's a way to expedite it, or if there's any sort of broad spec sort of steroids you should start if you suspect something autoimmune but just haven't quite got the answer yet.
Yeah.
Peripheral neuropathy or central autoimmune conditions, but.
So usually, when you're sending off these niche antibodies, there is an inevitable wait, and often and we're talking months in some cases. I sent off some like those ganglionic acetylcholine receptor antibodies for autonomic stuff. We sent some of those off, and they took months to come back. So you can't really rely on them particularly to guide your treatment, especially if there's a neuropathy that needs treating. I think probably the best way is just to find out which lab they get processed at, because sometimes you get results that have been issued, and then there's just a delay in the results coming back, and it's just sitting there waiting. So sometimes trying to find out which lab it's gone to, you can then ring that lab directly. And you can usually find out by speaking to your local lab, and they'll say, oh, they've gone to Portland Down do the Lyme testing, for example, and
okay, that's useful to know. Basically, it helps know unless you work somewhere like Oxford or London, where they will get processed on site.
Yeah, exactly. Yeah, but usually there's enough suspicion of the underlying process to help to guide the treatment. For things like vasculitis, it usually is it becomes pretty obvious quickly. You do have a high CRP, and you often do detect the anchor and something quite quickly, and so usually often you get, so the thing that often causes a bit of delays is the nerve biopsies. Again, when there's a bit of, I mean, it's more waiting for nerve biopsies rather than antibody results, which is when you're wondering about what you're treating and whether you should be treating it. So, but again, we're talking about a turnaround for sort of a week or so there, and if there seems to be a aggressive process and which seemed to be inflammatory, you'd often just give steroids or whatever, cyclophosphamide, because the process itself would seem to be relatively obvious, or would be that there's an inflammatory problem afoot. As the one, if I've got time, the one patient, the case study I used of the patient with systemic amyloidosis who had a lot of autonomic findings, his case was very difficult, just trying to seal the diagnosis, because amyloidosis is basically a diagnosis where to make the diagnosis you need tissue, you need a tissue diagnosis, and he was a Jehovah's Witness, so he couldn't have a kidney biopsy, which is usually the most sensitive. So he had a bone marrow biopsy, which was negative. He had a skin biopsy, which was negative. So all his biopsy results came back negative. So even though we were heavily suspecting amyloidosis, it was very difficult to get the diagnosis, confirmed in a organ. And in that situation, we went to the sort of quaternary centre, to the National Amyloid Centre, to help with the diagnosis. So if you're struggling, there's always hospitals, quaternary centres and things higher up, which can provide support and advice and things like that. So, yeah.
All right. It doesn't look like we've had any questions, so we'll stop broadcasting now. Thanks very much for coming, everyone. It looks like we're going to have a break for a couple of weeks, just with the rearrangement of sessions and such. So I think the next session is going to be the reduced GCS session on the 28th of April. So hopefully we will see you there. Thanks very much for coming.